Thanks for that introduction, Greg, and I appreciate the opportunity. I think I've done this each year now, and this has been the worst that I've in terms of my skill sets here. So hopefully the talk will be better. I'm going to jump right into it since we're a little bit late and talk about congenital scoliosis. And in terms of just kind of a broad definition, it's related to a vertebral anomaly. And why that's important is when I, uh, teach this, right? Doesn't necessarily mean that the scoliosis was, that the patient was born with a scoliosis in sense that they had a deformity in their alignment. But similarly, it also doesn't mean that every scoliosis that somebody's born with is congenital scoliosis either. And it comes in really two forms: a failure of segmentation and a failure of formation. And why this is important is for all of us who are spine surgeons, I think understanding a little bit about the embryology and how the spine develops, I think is important and helps to relate to a lot of the problems that we see and why there are associated findings in congenital scoliosis with other organ systems and so forth. So really going back and digging deep into embryology, essentially the development of a somite is what develops into basically two parts, a sclerotome and a dermamyotome. And it's this separation, and then there are multiple somatophyte or somites. But each sclerotome then separates into basically two levels. And it's this process, and especially the relationship for the sclerotome, which then develops into the spinal cord, and why each of the dermatomes and so forth are associated with each of the segments or each specific somite. Um, each sclerotome then separates into essentially two levels, and it's a loosely packed cranial level and a densely packed caudal area. And it's this separation and the space in between that actually forms the intervertebral disc, and it's essentially a cellular free space. In terms of the annulus fibrosis, it's formed from migrating cells from the caudally densely packed layer. The nucleus pulposus is developed from the notochord. And it's really the development of the intervertebral discs that then kind of force the densely packed and the loosely packed layers to actually fuse together. And it's really a balance between kind of this fusion and apoptosis process within each of the sclerotomes that then really forms each of the vertebrae. And so you can imagine if there is a process by which things need to fuse or things need to separate or things need to undergo apoptosis, you can see how if there's a aberration in this process, you all of a sudden start developing the congenital anomalies that we see. And depending whether it's a lack of separation, which is then really a failure of segmentation, or if it's an aberration in apoptosis, and then you have failure of formation. In terms of the other things that are important, and we think about our ossification centers and our synchondrosis of the spine, conjugification basically happens in terms of embryology about 6 to 7 weeks of age, and then bone starts to form about week 8. There are 3 primary ossification centers. And it's these neurocentral joints or synchondrosis that if you operate on a really young child and you're putting in pedicle screws, for example, you'll kind of feel that there is an area where there isn't actually cancellous bone that you can get through. And the vertebral arches fuse during the first year of life and usually are complete by the age of 6. I think the other important thing about spine development is, if you think about the fetal position, whenever we get into a fetal position, it basically is a C, right? So we're just kind of folded within ourselves. And it's really the initial spine is completely kyphotic. And it's really the development of the lordosis is when we start either holding our head upright for cervical lordosis, or lumbar lordosis really develops with sitting and then standing posture. In terms of congenital scoliosis overall, the incidence is about 1 in 1,000. Interestingly enough, girls are still more common than boys. And the causes are pretty various in terms of just certain insults that can happen, uh, to the fetus. There are some genetic incidences with some familial incidences of 1 to 5%, but I would say within majority of the population, I have yet to encounter really a familial congenital scoliosis that I was aware of. As I mentioned, there's really two classifications, failure of formation and failure of segmentation. If we go through and look at kind of what are the different types of failures of formation, really a wedge vertebra is an asymmetric vertebra with one side being hypoplastic. Probably the more common one that we think of is the hemivertebra, which is really the absence of half and usually the absence of a pedicle. In terms of other things about a hemivertebra that are important and that my eyes get directed to when I see one in a child is whether it's segmented, and so does it have a disc above and below, and versus an unsegmented, which a completely unsegmented is fused to the vertebra above and below. And remember that the growth potential for a vertebra really exists at the discs. And so it's that apophyseal ring that allows the spine to grow vertically. And so if you have a disc, that means there's growth potential. But if it's segmented or fully unsegmented, there's really no disc above and below. There really is no growth potential. The other things that can be sometimes helpful in a decision-making process is for hemivertebra is whether it's incarcerated. And the idea behind the incarcerated is that the vertebra above and below basically absorb the deformity. And essentially, if you kind of draw a line through the pedicles, the pedicle falls within essentially the pedicles above and below. Whereas one that's not incarcerated, it really is more like a wedge in the spine itself. And then the other one's a hemimetametric shift, and these are basically essentially two hemivertebras that are kind of contralateral to each other. And really, it's interesting. I would say it's not uncommon for us to see hemimetameric shifts, but whether it causes a deformity or not is kind of dependent on how close they are. So if they're one or two levels separated from each other, they balance each other. You can let those usually ride. But if you can imagine if you have one hemivertebra in the lumbar spine and one in the thoracic spine, they're probably likely going to cause their own independent deformity. As for failure of segmentation, there's the block vertebra, completely benign unless it's your entire thoracic cage. And so I have had patients that end up having, 5 to 7 block vertebra in their thoracic spine. And so this actually can lead to problems with chest development, vertical height of the spine, and ultimately compromised lung function. A bar is basically a one-sided connection. And we now know that a bar can kind of extend just beyond the spine itself. And because the ribs are relatively rigidly attached to the spine, even fused ribs can be a source of a bar for the spine deformity as well. And then obviously there's the mixed vertebra, which is essentially really uh, hard to always know exactly how these spines are going to progress because they're a combination of either hemivertebras and bars. Some are on the same side, some are contralateral to each other, and so forth. If we look at the natural history of congenital scoliosis and where can it be a problem or how does it lead to further deformity of the spine, it really is a little bit dependent on the type of anomaly, the patient's age, which means growth potential, and then the location of the anomaly. And so typically, anomalies kind of at the cervical thoracic junction or the lumbosacral junction are really kind of the most clinically visible. And a lot of it probably has a lot to do with the fact that at each of these junctions, there's kind of a hemivertebra relative to a rigid area, more constrained versus a flexible area. And obviously, lumbosacral can cause a significant truncal deformity, and a cervical thoracic can cause pretty significant head tilt. And usually, because of the fact that patient want to keep their heads upright, if there's a cervical thoracic deformity, it causes a pretty significant compensatory curve down below because patients like to keep their eyes pretty level. McMaster is still a pretty hallmark paper now that it's over 40 years old, where they looked at kind of the natural history in terms of the risk of progression. And you can see that if you have an area that's growing actively and it's on the other side of something that the spine is constrained in its growth, that's where the greatest risk is. In terms of other risk factors, I mentioned briefly about a presence of a rib fusion. Ribs themselves can be bars. And for some reason, the thoracolumbar region has been determined to be a higher risk factor for progression as well. As I mentioned, kind of with the congenital, this is where we can all be ultimately not just good surgeons, but good doctors. And that is because every once in a while we'll encounter a patient who's been diagnosed with congenital scoliosis who hasn't necessarily had any other areas of their body evaluated. And I mentioned before, in terms of understanding embryology and various different things can go array. It's these areas that can, or the timing of that, you know, uh, pathology development can be associated with other organ systems. And so, up to, depending on the complexity of the congenital scoliosis, this number is a little bit high, but up to 60% of patients can have abnormalities in other systems. And the best way to kind of remember in terms of the two most common, it's Vater syndrome or VACTERL. And you can see here that renal anomalies, typically a tracheoesophageal fistula, anorectal atresia, these are things that will be caught at birth, right? So Vater and VACTERL aren't in these situations going to be something that you're likely going to diagnose. But renal abnormalities or even subtle cardiac abnormalities are things that can be found. And for those of you who are orthopedic surgeons, there's nothing worse to miss than an orthopedic condition, somewhere else in a patient that has a risk factor. So don't miss the congenital anomalies of either the upper or lower extremities, or most commonly the upper. Renal abnormalities can be 20% of the patients, and these can be anywhere from, lack of, only one kidney to some subtle findings or duplications of the kidney. Cardiac, a lot of these cardiac things, again, if they're severe enough, are typically found at the time of birth. Or even, intrauterine ultrasounds. In terms of just how do these get evaluated, again, when I'm trying to be a good doctor, doesn't necessarily mean I'm doing everything to find it. I just want to make sure that somebody's looking for it. But if a patient is going to get an MRI, which we'll talk about in a sec, you will typically see the kidneys on the MRI. If you're not going to get an MRI, renal ultrasound is something that's pretty easy to get. And if you're dealing with young kids and you don't want to necessarily sedate them, a renal ultrasound doesn't need sedation. In terms of cardiac, now I'm not going to be ordering echoes, but these are things that, either I, make sure that there's communication with the primary care provider if there's a concern, or, would make a referral to cardiology. But the more severe cardiac things are typically found before they arrive with me. Things that you can find for the first time, though, are neurologic related, or specifically a spinal dysraphism. And these can be anywhere from a diastatomyalgia, I can't even say that word, but I know that I have to refer it to neurosurgery, a tethered cord or Chiari malformation, or other findings. And then I mentioned musculoskeletal. And for those, again, if you're an orthopedic surgeon, don't miss another musculoskeletal deformity. I'll go through these quick so we can talk a little bit about treatment, but good neurologic assessment and a good history will lead to it. In terms of imaging, plain radiographs start with, again, for us, these are all scoliosis films, so I want to see the entire spine. And remember that the entire spine, and talking to spine surgeons, this should be obvious, includes the cervical spine. But interestingly enough, I had a patient referred to me when I was in San Diego that had treatment for their congenital scoliosis in the thoracic and lumbar spine and never had an x-ray of their cervical spine because in the previous or in the other institution that they were treated, neurosurgery did, as a pediatrics, did cervical spine, and orthopedics did the thoracic and lumbar spine. And when they came and saw me, it was the first time as a teenager that they were told they had congenital anomalies that were in the cervical spine as well. CT scans, obviously, these are the best in terms of imaging bone. Luckily, we can get 3D recons, pretty much immediately. When I first started, these were special order and a little bit more difficult and not necessarily getting authorized by insurances all the time. But now we can get 3D recons and we can actually get them printed for surgical treatment. But these are pretty critical. Ultimately, I only get these from when I start contemplating surgical treatment, mostly because I want to avoid radiation in the pediatric population. But there's good studies that show that not even just the 2D views, but the 3D views will give you the best information as to the type of deformity, and where does the treatment need to take place if you're going to do some surgery. I mentioned MRIs. I will typically get MRIs earlier in the process, especially if there's progression, even putting a child under anesthetic if I see that there's progression of their curve. But if there isn't, then I'll delay them until usually we get past the black box warning for anesthesia of 3 years. Non-operative management, interestingly enough, is not all congenital scoliosis progresses, especially if there's a lot of failure of segmentation. You can have a pretty severe scoliosis, 60, 70 degrees, that doesn't seem to get worse because it's just kind of stuck there. And it's really important because it's not necessarily mean that that patient doesn't need to be treated, but the treatment for congenital scoliosis is relatively complex. And so the later you can get in life, ultimately, the better. Bracing is typically not effective unless you're treating the compensatory curve. But in mixed congenital scoliosis, where you don't really know where there's mobility and discs and other things like that, and we know that the patients are really young and we're trying to avoid surgery at all costs, we will still contemplate placing them in a brace. Uh, we're going to talk about operative management. I know we have 5 minutes, so I'm going to try to do this pretty quick. One is to prevent, and the other one is to correct. In situ fusion's kind of been a historical thing. It's really hard to just now want to fuse a patient and leave them the way they are. But the thought is, if you can fuse them with minimal deformity, then maybe you can prevent the deformity from getting worse. We do these in the legs, right? So we try to, suppress the growth on one side of the spine, or one side of a growth plate, and hopefully that allows the other growth plate to progress or continue to grow and correct the deformity. So in hemiepiphysedesis, again, very historical in nature and typically not something that we do very commonly now. Majority of what we do is some sort of fusion and instrumentation, and it really depends on kind of the complexity of the deformity and if there are compensatory curves. Um, my favorite operation, however, is a hemivertebra excision, and that's basically an acute correction followed by very short instrumentation. And it's really there to kind of take out that wedge and get the vertebra above and below kind of parallel to each other. Can result in a cure. And for me, the ideal age, and there's pretty good publications now on this, the ideal age is between 3 to 5, mostly because you can get away with screw above, screw below, or at least 2 screws above, 2 screws below one vertebra for 2 screws. As you get older and the patients become the operation gets more complex, the patients get more active, you typically are fusing 2 vertebrae above and 2 vertebrae below, almost kind of like a vertebral column resection, even though it's a hemivertebra. The other thing is these really young kids we can support in a cast and a brace, so we have kind of a belt and suspenders approach. Finally, the VCR for the severe rigid curves, the mixed anomalies, patients that are older. These are technically demanding procedures. And, in this population, not something ideally that we're looking forward to, mostly because of the significant risk to the spinal cord. And then finally, just fusionless surgery, use of growing rods or vectors. Historically, most of these were treated, believe it or not, with vectors, but that device is kind of really declining. And it just allows for continued growth. Unfortunately, these are typically more rigid. And so, of all the surgeries that we've studied for growing rods or vectors, it's really the congenital scoliosis that have been the least satisfying. So just in summary, and I think I'm hitting the 30 minutes. Sorry for being a little late and running through this a little bit faster, but in terms of really, I think the value is understanding the embryology and the development of the spine. When we look at congenital scoliosis, really understanding the progression of deformity, I never jump on a congenital scoliosis the first time I see it, even if it looks severe, because even a severe curve may not change. And then it's really balancing this idea between deformity correction versus complication. And the more aggressive the deformity correction that's required, potentially the greater risk of complications. Thanks. There's more to it, but I think we're running out of time, so I don't want to.
Hey Bert, what would you say is like? Hey, thanks so much for giving that. I always love listening to it. What is there? Do you feel like in the last 5 years there's been any like significant changes within the management? Like
Yeah, that's a
that you
great
would say from
question.
a trend standpoint, here, we're definitely not doing this anymore. We're doing more of this.
Yeah, yeah, I think the only significant change that I would see is that we're waiting longer before we use growing rods. And I mean, we're doing that for all pediatric or, early onset scoliosis, but I think in this population, I think we're even pushing that farther out. When they're pretty complicated, I think we're doing a VCR in a previously operated segment's obviously more complicated. And so trying not to mess up the spine before we do a more complicated operation, I think is our goal.
And do you feel like do the numbers still hold true for like hemivertebrae when it comes to doing, because like when you do them when they're, 2 and 3 years old, the surgery is actually, you know, all things considered, probably on the simpler side, right?
Yeah.
Um, when you talk about doing a VCR, it's probably the most fun VCR all of us talk about. Uh, do you still feel like we're using the same numbers that we always used, or do you think you're getting a little bit more aggressive because we're better at the operation and can,
Yeah,
more over there?
yeah, I mean, I think we're better. I mean, I think, for the past probably 15 years, cervical spine instrumentation has been more robust. And so we use that for thoracolumbar in, 3-year-olds. I mean, we're pretty aggressive, I would say. I usually quote that we're getting about 30 to 35 degrees of acute correction with a hemivertebra excision. And so even in a complex congenital scoliosis, if there's a hemivertebrae in there, even though I know I'm not, treating the entire spine definitively, my thought is if I can get a portion of that segment straight, that's going to be irrelevant in the future, future additional surgery. So I'll try to look for a mixed congenital curve that's complicated, even if it's a 80 degrees, 90-degree curve. I'll look for a single hemivertebra to try and see if I can pluck that out and then get that portion of the segment straight, even though I know I'm going to have to come back later and deal with the rest of the curve.
You're essentially trying to change the natural history of sorts of the rest of it by
Yeah.
operating on one part of it.
Yep. And I just figure, I figure that, especially obviously if it's progressing, if I can get 30, 35 degrees correction and take a 90-degree curve and make it somewhere between 50 and 60, then I got a little bit of breathing room before I got to jump on it again.
Love it.
Strategy.
Unfortunately, I have to jump off to another
Okay.
meeting,
Yeah, no
but thank you
worries.
so much for the invitation.
Thanks, Burt. Appreciate it.
Thanks, Burt. Loved having
See
you.
you soon.
Awesome.
See you, buddy.